All right, well, welcome everyone. We are continuing our CROI review series. Today, Dr. Katie Riggs is going to be presenting on neuro-HIV from CROI. But for those who don't know Katie, she is a fourth-year fellow in the Infectious Diseases and Global Public Health Division at UCSD. She's got some very cool stuff in her background. I'm going to give the highlights. After she graduated from UCSD in bio, she joined the Peace Corps and served as a community health educator in 2 years in Kenya, where she focused on HIV. And she worked at the HNRC for a while, which solidified her goal to become a physician. She went to Kansas City University of Medicine and Biosciences. And then after graduation, she did her internal medicine residency at Scripps Mercy in San Diego. And then she began her ID fellowship in 2020. And in addition to all the clinical training she's had, she's pursuing research focused on the neuropsychiatric effects of viral infections and associated immune dysregulation. And probably the biggest news of all is that Dr. Riggs is looking forward to joining the faculty after she completes her fellowship this summer. And I think that's official, so I can
almost
say, yay, okay, almost official. But yay, we're so excited. And she may talk a little bit about her K, I'm not really sure, but obviously she's going to focus on the CROI review today. Katie, I'll keep an eye on the chat. And this is a reminder to everyone, best to put comments that are for clarifications into the slide. If you have general questions for the end, you can write them down, send them to me at the end, or send them to me privately, because I think we don't want to take anything away from the speaker when they are not able to look at the questions that are coming through. So anyway, Katie, on to you. We're excited.
I'm excited. All right, so we'll go over some CROI 2024 review of neuropsychiatric complications in people with HIV. So just kind of broken it up into 4 sections, which is basically HIV persistence in the CNS, which was a major focus this year. And then just kind of some updated information on prevalence of neuropsychiatric conditions and a little bit on pathogenesis and diagnostics, kind of what's in the wings, and then therapeutics, although spoiler, there is no big breakthroughs on that part, but we'll go through it. So HIV persistence in the CNS. So this is a big topic. Maybe this is starting off a little bit defensive, but it does matter about the HIV persistence and the CNS reservoir. There is the relevance to, even people on ART, as we'll go through, have ongoing transcription, and it does negatively impact brain health. And so one day maybe we'll have a way to quiet that reservoir activity. But especially as more and more cure intervention trials are being planned and getting underway, it's very important for us to remember all of the different tissue reservoirs, including the brain. And so this was just my note to us all. And then if anybody is particularly interested in kind of what we know and specific considerations for cure research going forward for the CNS reservoir, Sharon Lewin did a great little mini lecture during CROI, which is, the video is available, and I think it's less than 20 minutes, and it is definitely more in detail than I will go into. So just to go through some of the important ones that were presented during CROI this year. So this is just the reminder that basically the low levels of HIV in the CSF are associated with neurocognitive impairment and inflammation. So this being the reminder that transcription matters in a clinical way. And so they had 78 people with HIV who'd been on stable ART for over a year, and there were no neurologic symptoms. So this was just routine research enrollment. And they measured HIV RNA in blood and CSF by standard assays and also single copy assays, and measured 12 inflammation-associated protein biomarkers, and then did 11 neuropsychological tests. And what they found was not particularly surprising, but is worth mentioning that there was in the CSF, there was increased MMP9, which is most associated with kind of cell trafficking and blood-brain barrier dysfunction, which does make sense in this case, as well as CSF total protein was higher. And they also demonstrated that there was, even with just single copy assay detection, but still less than 40 copies, there was still worse overall global neurocognitive performance, and especially speed of information processing was diminished as well. But you can see that kind of executive function and gross motor were also a little bit trend level or borderline there. And then going more into kind of what the reservoir is made up of and kind of the current unknowns is we have background, and I think you guys have heard from Davey Smith and Sarah Gianella from Last Gift about kind of the phylogenetics and what's been shown so far, that basically going to the reservoir in general, we've been able to show that there's identical HIV sequences in multiple sites throughout the body in people with HIV on ART, in addition to compartmentalization. But these identical sequences, it's not known if this was, remote seeding that occurred before ART that basically seeded into those different tissues, and then, additional mutations were kind of arrested because they started on ART, or that whether T cell clones that continue to be activated and the T cell clones actually replicate can continue to seed distant sites while on suppressive ART. And so that's what Dr. Farhadian did in this study, and her group did in this study, is they had 7 people virally suppressed on ART. They then measured or took PBMC's CSF, and they analyzed the host transcriptome. They looked at the T cell repertoire, and also measured viral HIV RNA. And just of note about these 7 people, so they had long duration of HIV and had been on ART for a median of 19 years. So very stable, very long history of ART, and were documented to be virally suppressed in blood and CSF and asymptomatic. And so what they found was they identified HIV RNA transcripts in 5 of the 7 individuals. They found 36 different T cell clones, and what they found was 78% were compartment specific, so not shared across blood and CSF, which is a little bit counterintuitive when you look at their title, which was infected T cell clones are shared across CSF and blood compartments in PWH, which it is true, some were shared, but that was not the majority. And so you can see kind of, I don't want to go through the whole little figure here, but the top panel is basically the different clones. And so you can see in kind of the pink circle, these are like singlets. So there's not really a lot of clonal expansion in this case. But if you look at P4, each cluster is a clone basically. And so this whole cluster here, oh wait, sorry, can't see. Can you see my, I don't know if you can see my pointer, but P4, so basically the middle thing is a huge clone, and that's CSF and blood mixed together, versus this one is just a clone that's only seen in the blood. So, and they did find that identical clonally expanded T cells produce HIV RNA in the CSF and in the blood in some people with HIV, despite years on ART. So that's this bottom panel is the all the black ones are ones they did not detect HIV RNA, so transcripts in, but you can see, so say for P4, this large clone that had some in CSF and some in blood, this was identical sequences in blood and CSF, and the same thing for this clone here. But for most of the clones, it was actually pretty segregated between blood or CSF. And so this is important to know, because it contributes to the CNS reservoir and documents that even on ART, we would like to think that the longer you're on ART, the reservoir just slowly kind of declines and becomes less competent, and over time it's eventually going to go away on its own. But this kind of shows that as T cells get activated, the ones that have HIV in them can clonally expand, and those T cells can likely, doesn't prove it, but likely can go and seed other tissues, and so contribute to spreading of the reservoir while on ART. And so limitations, this is CSF, so not brain, but CSF is still important. And this is viral transcripts. This is not proviral DNA, and we don't know if it's replication competent. And then, so going on to the next one, which was by Melissa Churchill, and I did just cut and paste one of her little background slides because I thought it was quite nice. But basically, she showed HIV transcription persisting in the brain of people with HIV and viral suppression. And this is actually based on last gift from us here. And so just kind of going through what is known about CNS reservoirs in people on ART. So the reservoirs still exist, yes. It has been documented that the reservoir still exists. There is proviral DNA, but also in kind of indirect measures, they'd shown that there are intact genomes, and which is the next part here. And then the most recent and kind of some of the most exciting and what had been huge controversy was whether those intact genomes are replication competent in the CNS after ART. And I guess, unfortunately, they are. And so this was also based on last gift and done at UNC with Dr. Tang and Gauchen. And so they did isolate virus from CNS myeloid cells after rapid autopsy, took those, multiplied them in ex vivo, so in culture, and were able to induce them to produce replication competent virus that was then able to actually infect T cells and myeloid cells. So that is important for thinking about kind of cure in the future of we don't want to just target what's circulating in the blood. And we have to figure out how to get into the brain and what that means if we do. And then which cells harbor the reservoir. So there's been some controversy about whether it was actually like T cells that have seeded the brain that is what we're actually picking up, but more and more studies have actually shown it is the myeloid cells and astrocytes that are infected. And then, so what this Churchill looked at here is kind of how active is this reservoir. Okay. And so what they found was HIV transcription persists in the brain of people with longstanding viral suppression. Basically, no significant difference was seen in the kind of rate of transcription levels between the brain and periphery, which was important because it's typically thought like, yeah, there's, the ones in the brain aren't as optimized and likely to have quite as much transcription going on. But while the number of cells that have HIV proviral DNA in them in the brain are hard to find, and there's fewer of them, they are just as likely to be transcriptionally active as anywhere else. And the transcription levels did correlate with the reservoir size, and they did this by intact proviral DNA assay. And then they also confirmed that this was the transcripts were in myeloid cells in the brain, not trafficked T cells. So you can sort of see this over on the left. Basically, CD3 cells here and here were, I'm on the wrong screen here. So basically, CD3 would be the T cells, CD8 would be the myeloid cells, and then P24 would be HIV. So what they showed was you can actually see them co-localize. The P24 co-localized with the myeloid cells, did not co-localize with the CD3 or T cells. And so there is transcriptional activity. And then, so long-term, the next one is from Dr. Tang and Gautran at UNC, also based on last gift, you can see a theme here. And that's not just my bias. This was, there were lots of them at CROI, just showing the benefit of a rapid autopsy. So, oops. This was building on her prior work, so showing long-term survival of microglia with HIV infection contributes to HIV residual expression in the brain during ART. So a little background is, thought that, microglia shouldn't live all that long, so they should have just died off, after decades. And why wouldn't they just kind of turn over? HIV would be gone, there'd be no reservoir, especially if they're on ART and there's not ongoing new infection. But what they showed was that the brain myeloid cells were resistant to cytopathic effects after viral infection. So they actually, did not go through the normal cytopathic protective mechanism of killing cells that are infected. And so, sorry, just apparently my mouse is very touchy. Okay, so basically, so each of these panels are showing, so there was extended survival of the microglia with HIV, and there was no change in viability between those that were infected and those that were not. And then this is in PBMCs, and there is a significant cytopathic effect that you can see in this sharp decline on the dotted line versus in the microglia that did not decline. And then we don't have to go into the actual cell markers, but they did show that the main differentially expressed kind of genes were related to cell survival. And then they also showed, which was interesting, was that ART may be ineffective at blocking kind of established infections. So meaning that if you look at, say, PBMCs, you give ART day 0. The ones who got ART, you don't detect P24 anymore. The ones that don't get ART, it kind of slowly builds. And even if someone or if cells are already infected, you give ART, then P24 comes down in PBMCs or in the plasma. But they did not see the same thing in microglia. So microglia, if there weren't any new infections, if you exposed to ART, but there really was no difference kind of in P24 expression or antigen expression in the presence of ART. And this is in a cell culture, which I would kind of expect to be very robust exposure compared to probably what's in vivo. So that's interesting to note. I don't think we quite know what exactly to make of it. And so just brief summary, HIV transcription continues in the brain and in CSF on ART. And that does have adverse effects even at the single copy assay level. And then brain reservoir has replication competent virus that can infect T cells. That's actually older data, but it's important. And so we don't know what might happen if CNS is not targeted in cure strategies. If you don't clear it in CNS and you go on a treatment interruption, we don't know what that means in the brain, whether that means there will be ongoing inflammation, replication, et cetera, that leads to neurotoxicity, or possibly even reseeding other tissues and coming from the brain. But we also don't know what happens if you do target it. So, and what neurotoxicity and adverse effects there may be if you have treatment that specifically targets the CNS. They do have some early studies with like latency reversal agents, some of the older ones in isolated exposures with a single dose that didn't show any neurotoxicity, but I don't think that's adequate. And so I would argue that cure trials without a neuro component are incomplete. And I hope that you agree with me and advocate for that in the future. And that CSF is often the best we have. Obviously, in our participants, we're not going to do brain biopsies, but CSF is not truly reflecting the reservoir in the brain. And so moving on to just kind of updating prevalence of neuropsych complications and some of the associations. And I think it is important, there was a focus this year on kind of beyond Europe and the US. And so, which I think is important for us to note the different populations, the different findings, and how applicable that is to our patients and participants. So this is good news. So basically, this is looking at changes in cognition, mood, sleep following efavirenz to dolutegravir switch in South Africa. So there had been early on, there were some concerns that dolutegravir may also have some CNS effects, similar to, although less than efavirenz. So they had this perfect cohort where everyone, as formulary changed in the country, pretty much people were all switching from efavirenz based to dolutegravir based. So they evaluated them at baseline when they were still on efavirenz. They switched to dolutegravir 1 year later, reevaluated. And they also had 95 sociodemographically similar people without HIV. This is what they have said. They did not give us any information about what that actually meant. Okay, so, and they did do good assessments with 7 cognitive domains. They assessed sleep, they assessed mood. And so cognitive impairment in people with HIV versus people without HIV. So baseline, while they're on efavirenz was significantly different, as you can see here. So there's 30% basically of people at baseline on efavirenz had cognitive impairment. Or people with HIV, people without had whatever, 11.7%. So very different. Then at follow-up, these same people did not have any difference. So there was no difference at all in cognitive impairment on dolutegravir in the same people 1 year later, which is awesome. And also sleep improved on dolutegravir, so that was also good. So you could look at this and say, all right, this is fantastic. Efavirenz was the problem. It caused lots of neuropsych stuff. It caused cognitive impairment, and now we're fine. And HIV is not causing anything. But I don't think we can quite go there. But it's still encouraging. But it's important to note that there is, there were no mention of demographics at all in this poster. So I have no idea how old these people were, if they were male, female, like there's nothing. I even tried to look to see if like this cohort had already been published. I couldn't find any information about that. And it does come from a group who does have a bias. I'm not saying I don't have a bias, but does have a bias against the existence of hand or HIV associated anything. So it does make me question it a little bit, but I'm still going to take it as a win. And overall, it is encouraging. But my guess is these people are pretty young. But still, that is real improvement that was shown in the same participants. So there's that.
I actually didn't think you could do that for CROI, that you have to have demographics and very specifically, assign sex at birth and certainly age. So there's something off on that. And I don't know, I wonder if it's worth pursuing this further, maybe after. But there was a question,
Yes.
Katie, I think from the study right before about from Dr. Looney, was the brain targeted in any of the transplant patients achieving functional cure?
Oh, that's good. Yes. So not directly. So in the sense that, they got, if we're talking about kind of Berlin patient, Timothy Ray Brown, the initial ones, got the CCR5 deletion, bone marrow transplant, and there was no specific targeting of the CNS. However, they had major, so like Timothy Ray Brown had whole brain radiation, and he had 2 rounds of very significant myelo and lymphoablative therapy or preconditioning before his transplants. So in a sense, yes, I think they did have CNS targeted interventions that we are kind of overlooking when we're looking at the newer strategies that do not include any of this ablation, which is great. There's no immunoablation, but I think we do need to differentiate between the early ones versus kind of the cure strategies that are being proposed here. But I could have put you in the audience as a plant because that's a question I wanted. So thank you.
And then just quickly, Shannon asks, did they quantify the depression change from the year prior, and was it clinically significant?
The depression?
Yeah.
Improvement, yes, it was. I can't remember, but it was, the depression on this study, yes. So this was actually very weird because at baseline, the depression level in the people with HIV was extremely low. Like it was like less than 1% or like something ridiculous and very, very odd. And so then and the people without HIV, it was like 6% or something. And then at follow-up, both groups were at like 6%. So
Something
I
sounds
think
strange about this study entirely, that maybe we
it
need
kind of
a
does.
new
So
review on later. Yeah.
yeah, it was a little weird.
All right, then we
But
can
yeah,
move on to the next one. Sorry, there just happened to be a bunch of questions related that
yeah,
came through.
I also had a bunch of questions about that.
Okay, fair.
So, okay, so then verbal learning and memory in a well-controlled HIV is similar to people without HIV in Uganda. So Africa is doing awesome, is almost what you would think here. But so this is a community cohort study in Uganda. They had good numbers, 350 virally suppressed people with HIV, 250 sociodemographically similar people without HIV. They did provide information on that. And what they did was basically one test with two measures. So they did a verbal learning, which was just learning a list of words, and then tested memory as recalling that list 20 minutes later. And there was no difference between people with HIV, people without HIV, which, so more yay, as I said, but a couple caveats. So this is a very, very brief assessment, which really does not, isn't a full neurocognitive assessment. This is much less than even a MOCA or anything like that. And the population is also very different than I think what we mostly see locally. And so overall, I mean, things change as my age changes, but I think these are very young people with the mean age of 44. And so I think that's a little bit different, and also a lot less comorbidities. So like almost no diabetes. There's a little bit of obesity, also much lower levels of education, but nicely split male female. Very little hypertension. There is tobacco use, which I think would be the major comorbidity, but other than that, they're a pretty low on the comorbidity scale and fairly young. And this is a very brief assessment. So I'm not ready to get too excited about.
I'm sorry, I just quickly looked up the life expectancy for Uganda and a lot of these countries where it is actually much, sadly
That's
much
true.
lower. So
Okay.
I just looked really quickly. It's about 12 years lower than the United States. So
Okay.
right, everything probably gets a little bit shifted forward.
Oh yeah, that's a good point.
Something to.
No, that's an excellent point, because yeah, if you add about 12 years, then that's kind of what a lot of our cohorts are. Yeah. All right, so that is good. And then so this is just showing another, so not everything is perfect in Africa. And so this was a larger cohort, so 27,000 or 2,700 people. They did do a larger 5-test cognitive batteries, and they did see that Z-scores were lower in people with HIV than without HIV. They initially do not present the number, but I do know the people, so I asked. And so they actually did see about 26% of people with HIV who were virally suppressed were impaired, on technically cognitively impaired. So that is more consistent with kind of other cohorts and other numbers we have. And then they looked at 4 inflammation-associated protein biomarkers, and there was greater inflammation, except soluble CD163, surprisingly did not have any association, but the other ones were associated with worse cognitive performance, even with viral suppression. And these biomarkers did not associate with cognitive performance in people without HIV. And motor performance had the strongest associations, which was kind of a theme, I feel like, during CROI this year, of motor and inflammation seem to be most strongly tied together. And so, yeah, so I guess part of the point of this one is even in Africa, there still is cognitive impairment, at least in this study, and it does associate with markers of inflammation, which makes us think that it probably is something real. And then kind of switching to mood disorders. So mood disorders are prevalent, which I would imagine everybody here knows. But it's interesting to see kind of in a couple other countries. So in Lebanon, they found 61% or 62% had depression, 46% with anxiety, and they were very, very strongly correlated with self-reported levels of HIV stigma, which is very high, and the numbers have been increasing. Incidence of HIV diagnoses in Lebanon has been increasing. And then, so in the US, there was a study that showed 34% of people with HIV had depression, 9% of that was undiagnosed, which doesn't sound too horrible to me. I'm not sure what the regular population or the general population has, but I would imagine 9% undiagnosed depression is not uncommon. But they did find that undiagnosed depression was most common in transgender people, cisgender men, people with a disability and food insecurity. And they also broke it down into people who, so this is like among people with, people with HIV with depression. So 55% had a diagnosis without without symptoms. 19% had diagnosis with persistent symptoms, and then 26% were undiagnosed. And so they found that diagnosis with current or persistent symptoms was associated with being on disability, and then also social determinants of health, including reported measures of discrimination in HIV care. And then looking in Uganda, so they applied is quite a theme in my work, but also kind of multiple different groups are doing a lot of the machine learning to try to find kind of phenotypes and clusters of people that may be more biologically relevant. But they found 4 different clusters with machine learning, which don't separate that much compared to our regular clinical assessments. So there's prominent PTSD symptoms in one group, prominent anxiety symptoms in another, and then there's mixed anxiety and depression in another group, and a 4th group that had minimal symptoms. But they do note that, especially for the PTSD group, but also the other anxiety and anxiety depression groups, early life adversity and especially sexual abuse was one of the strongest risk factors. And then, sorry. And so I think it does highlight the importance that we need to address the psychosocial challenges, but also we don't always measure this. And so it needs to be measured as well.
Katie,
And then
there's a question from Nettie
yeah.
about the background depression prevalence in Lebanon, and I was just trying to look online. Did they present it, or
I did not see that.
Yeah, I think it varies, but Nettie, I saw something about 25%, 30%, and I'm sure it'll vary across studies. But
yeah,
it sounds like it was not presented here.
I don't think I saw that.
Is there a number that we use for the US in background rate?
What is it? So 20%. I think it's just 20% will have it. Is it lifetime. And then women, I think it's 50% will have some episode of depression.
Yeah,
But I'm
see,
totally
I just saw something from NIMH, 10% in adult females, 6% in adult males.
at any
Lifetime?
one time.
Yeah.
Yeah.
And that's major depression. So, right.
Yeah.
So just putting that
definitely
out there
higher. Yes, thank you.
yeah.
That is
Yeah. Okay.
cool.
I'm
And
your
then
assistant today.
I
So,
appreciate it.
okay.
You're a good assistant. Fantastic. So then we have some trends in suicide-related emergency department visits among people with and without HIV in the Bronx. So not across the border, but still relevant. It was a late-breaking poster, so I wanted to include it. So it does show nearly threefold higher rate of suicide-related ED visits among people with HIV compared to those without. Still overall low, but if you consider the amount of people that go to an ED, that's still significant. And in people with HIV, the highest rates of suicide-related visits per 1,000 ED visits were for non-cisgendered individuals, 31. Or sorry, this should not be percent. I did that wrong. So 31 per 100 or per 1,000 ED visits. Younger ages, non-suppressed viral load, and injection drug use, which is not too surprising. I did like these plots because it does clearly show that the COVID era, as you see, but you can clearly see that there was a steep incline starting prior to COVID for the younger individuals and men and women with HIV, whereas you didn't really see that in the general population or without HIV. And then I thought this was also interesting. So life years lost associated with mental illness in people with HIV in South Africa and North America. So this is all based on kind of EMR records and ICD-10 codes. But they did show actually fairly consistent pattern, and it was significant in men and women. There were some important differences, but basically people with HIV with a mental health diagnosis die 1 to 17 years earlier than people with HIV without a mental health diagnosis. And the vast majority of that excess mortality is due to natural causes, not accidents or injuries or violence. And then the organic disorders, this is mostly basically associated with dementia or TBI, etc. And psychotic disorders have higher risk, but I think it is something to keep in mind. And then just pathogenesis, future diagnostics. So they did, this was a scenic study that was really interesting. It showed associations between depressive symptom severity and incident stroke among people with HIV. So strokes were adjudicated in the EMR, but reviewed by a neurologist on the scenics team. And stroke risk was considerably elevated with new onset depression and with higher depressive symptoms. So interestingly, people who had had depression for several visits prior to having a stroke weren't as high of risk as people who had had new diagnosis of depression in the visit immediately preceding the stroke. So that's the new onset. And the higher severity of the scores were associated with higher risk score, especially in people under 50. And they did also break it down by sex, because last year there had been shown in younger women that there was a much higher risk of stroke, but they don't see that relationship in this analysis with looking at depression symptoms. And so they said that maybe suggests depression may be a modifiable stroke risk factor I'm not sure. I think that's overstating it a little bit because I don't think we know that there's a causal effect here. It could be, that the depression is also thought to be kind of inflammatory and can go up with some of the same things that would put you at risk with a stroke. So more to come, but interesting to note. And then a few imaging studies. So I'm not going to go into deep detail on this, but I think it's important just to go through a couple different imaging studies which show different imaging techniques and show significant differences in people with HIV who are virally suppressed versus people without HIV, and had good comparison groups. And so this is, I was not familiar with this, but neurite orientation, dispersion, and density imaging. So this is a MRI technique, and it is characterized as structural abnormalities. And so it measures, especially like the neurite density index. So basically how dense the neurites are and how disorganized or organized they are. And you can see that on cross-sectional analysis, there was significant difference between in the key regions between people with HIV and people without. And then they also did a longitudinal analysis 1 year later, or sorry, 32 months on average later, and showed that in people with HIV, actually this continued to decline. So they continued to have worsening or lower density of the neurites and more disorganized neurites. So I think this is pretty strong and concerning evidence that there still is something going on. So we can't just say neuro stuff is in the past, and that we do need to look more at microstructural changes and perhaps functional changes. So we have, this was fMRI, basically showed, this was in 56 people, I think 39 people with HIV who were suppressed, and then the other were people without HIV. And so looking to the left, this is 3 different states, basically, of different tasks for the fMRI, and how well it related to neurocognitive tests that were done outside of the MRI. And so this group down here is actually the people without HIV. And you can see that there's very, very strong correlations between the fMRI findings and the different neurocognitive tests. That really falls away in people with HIV. And so they interpreted this as kind of cognitive performance was less with functional network organization. So I think besides being kind of almost purposefully obtuse, I think basically they're saying that the clear kind of structural and connectivity that we expect is not the same and as in people with HIV as people without, and that inherently that's less organization in kind of standard cognitive processing. And then they also showed there's less optimized global functional brain network. So this is people, the gray is people without HIV, people with HIV is white. And so you can just see that there still is much, sorry, I keep pointing to the wrong area here, but there's much lower changes in these fMRI in response to different tasks in the fMRI in people with HIV. So more to come on that, but I think it is interesting in that I think these show possible ways for us to monitor for these subtle changes in the future, although very expensive. And in the interest of time, because I will probably share this at another time. I will skip this because it's mine, but basically biomarkers, we looked at a bunch of different ways to measure psychological outcomes, and then a large panel of biomarkers. And there were, each one there was some overlap, but mostly it was distinct. So this is trying to get us towards this more, higher level machine learning grouping that can actually point to biological differences. We're not there yet. We're getting there. And it also reemphasizes what I said was a theme of motor dysfunction seems to be very highly correlated with inflammatory pathways. Therapeutics. Oh, just to add. I don't think I included one, but basically multiple abstracts and posters showed polypharmacy is bad. But it's obviously hard to disentangle that from the comorbidities that it is trying to teach or treat. And so this was Tessa Moreland's study. Probably are familiar with Dr. Ellis talking about it and trying to recruit for it for a while. So this was synthetic growth hormone releasing hormone for treatment of cognitive impairment in people with HIV who also had abdominal obesity. They had 24-week course, tesamorelin, immediately or after 24-week delay. Waist circumference changed as expected. Cognitive performance did not change. So they are still looking at other kind of secondary and exploratory analyses, but it was disappointing. But it is also important to keep in mind that 24 weeks isn't a lot of time to undo cognitive impairment. And also it's always easier to prevent than to treat, just harder to get the numbers in a clinical trial to prove it. So I don't think it completely throws it out the window. And then there was also
Dani, was that from 2023 or 2024?
2024.
It is 2020. Okay. I was like, is that hot off the presses? Got it.
Yeah, no, I just
got it. Just wanted to
forgot to update that. But yes, thank you. Yes, it is. So then epigenetic impact of CSF cells from 48 weeks of adjunctive telmisartan in acute HIV. So basically this was, telmisartan has been investigated. It is an ARB, but it also has been shown to have some anti-inflammatory effects and antioxidative stress effects. So it was given to people with acute HIV as soon as they started their ART. They took it for 48 weeks versus the other group was ART alone. They looked at biomarkers. There was no difference between biomarkers. So then they looked at kind of epigenetic states of different genes related to inflammation. They did see that there were differential methylation or epigenetic signatures were different between the people on telmisartan and not on telmisartan. They do more closely approximate. So this is an HIV negative or people without HIV is in green. And so most of them more closely approximate. So in telmisartan group, the methylation levels more closely approximate normal or the comparison group, whether versus the ART group alone. Don't know what to make of this. At 72 weeks, after they had stopped the telmisartan, this all washed away. So it's not a permanent thing, but more to come. And so for summary, there does seem to be some decrease in cognitive impairment. So that's good. I think probably has to do a lot with the earlier treatment initiation. Our current ART medications are better, and more careful comparison populations and accounting for some more of the social determinants of health, as well as younger cohorts with few comorbidities helps. But even in the setting of stable ART, mood disorders still a significant burden, age-related comorbidities still significant burden, and are associated with cognitive decline. Brain pathology still shows HIV transcription and associated neuroinflammation. Imaging still shows abnormalities. I think I skipped the microglial activation, but there was one that showed that that correlated with cognitive impairment, and then microstructural issues or abnormalities and functional imaging abnormalities. So there still is something going on, even in the setting of ART, and then with cure strategies really taking off. I think there's a lot of major uncertainties and risks that we need to be very careful about. And apparently the font very much changed here, but take-home points going on from that was basically always up there. Monitor and manage modifiable risks the best we can. We know that helps. And basically diagnostics, we don't have anything new, but I'm really hoping that some of the imaging and biomarkers may help with precision for diagnostics soon, but also for monitoring in cure trials. And always keep fighting the good fight for more equal, equitable, inclusive society, so we have less of the trauma and stigma to make worse outcomes. And that's my story. Is it really 8:58?
A very good story.
Oh, thank you.
I think let me make sure. I think I went through all the questions.
Oh, and I remembered to thank CROI committee for my early investigator scholarship.
Oh yeah, that's great. Nettie, you may want to, let me ask, does anyone have a question or comment? The first one that has come through is from Nettie. And Nettie, it's long, so you may just want to unmute yourself.
Yeah, it was more for discussion, but we ran out of time. But I was very interested in that suicide slide, since it's pretty clinically relevant for our patients. But I think it was interesting that it was all people who were younger, who use drugs, or who are non-cisgender, and those are folks who are more likely to have HIV and also might independently have suicidal risk. So, you know, before we say that that's a direct correlation, you'd have to compare it with a comparable group of people who are also non-cisgender, also younger, also using drugs, and see what their rates of suicide were.
True. And actually, I didn't show it, but they did do that. But I didn't include it in mine. But they did have a giant table that showed that. And it did look worse in the HIV people with HIV, but you're right, there was still the same trend. Trying to see if I have it.
I just want to, saying HIV is independently associated with 3 times more higher risk of suicide is a pretty dramatic thing to say. Obviously, we know that our patients have suicide risk often for their other comorbidities, and so we're very thoughtful about their mental health. So it doesn't really change what we do, but to say that there's that direct clinical association might be suggesting a neurocognitive impact. So I'm really interested in that part.
That's a really good point, and I appreciate. I will look into that as well. Thank you.
I'm just talking to myself here. I was saying thank you, Katie. This really was a very good summary of all things neurocognitive at CROI. So I think really helpful for those of us who don't always wander in that area. Really appreciate it. And hopefully we'll have you back to talk about some of your own research when that's ready. And just in the interest of time, since it's at the hour, we'll see everyone next week. Marvin, remind me, I think we continue the CROI series next week.
Yeah, it's going to be Dr. Tom Martin on therapeutics.
Thank you so much, Marvin. Anyway, thanks everyone. Have a wonderful weekend, and we will see you next week.
Thank you. Bye.
Bye-bye.